Good evening, dear colleagues. I'm very happy to see you on my YouTube channel. Today I will try talk about causality assessment as a stream because thank you for your question. I received many interesting questions and decide talk as a stream that you can ask comments, questions, and we can discuss about this topic. And I will be thankful that you will write topics which you like to get new knowledge about what, for example, this can be clinical aspect of pharmacovigilance, drugs safety, it can be medication errors, because I am now in, I finish, I'll explain. I'm writing now book, several books. First of all, is clinical aspect pharmacovigilance. I'm finished it already, and it's now in format of electronic book, basic course of pharmacovigilance. Plus, I'm thinking now about writing a book, and I'm started to write a book. It's a post-traumatic disorder, because what I find out that drugs response sounds different. It looks like difference in patient with chronic stress and patient with inflammation. I think it will be articles and books too afterwards, and it's interesting actual topic. And for Ukraine, it's interesting topic. I have analyzed it, for example, trends of disease which took place in veterans from Syrian war, Vietnam war, Afghanistan war, and I see that there are strict relations and correlation between post-traumatic disorder and neurodegenerative disease like Parkinson, like Alzheimer's disease, chronic inflammation, and these metabolic disease disorders. And what's very important, and society has a relationship between cancer. For example, there are markers which show hypermethylation of DNA and high stance proteins, and it's and different signs in men and women, gender difference too. I think that we just in the beginning of understanding this molecular mechanism of it. And if you have any questions about this topic, I will thankful for this question, because when you're thinking, you make investigation, you write an article, you write in books, and networking, it will have big influence and help solve any problem. And this too, we have now many new drugs and new challenges, and very important to have drug safety pharmacovigilance drugs knowledge, because today you are a medical doctor, tomorrow you can become patients. And this actual topic for everybody from us. For our new participant, I start to introduce myself, and like I do all time, I went in science. For my new participants, let me introduce myself. My name Galina Cordera, medical doctor, QPPV, head of pharmacovigilance department, clinical expert, DCK Pharmac. I reflected in my presentation and my YouTube channel, Drug Safety from Galina Cordera. Please subscribe on it, and I will upgrade my website. Now it's in now in progress on medicine.net. Please visit, and I hope you will find interesting information personally for you. Today we will talk about causality assessment. So we will talk about case studies because theory will be not enough. We will illustrate with examples. First of all, we should understand causality assessment in adverse event reporting. The significance of causality assessment in healthcare contents, when we talk about it, we should understand the importance of causality assessment tools in healthcare. Taking into account causality assessment tools are vital for ensuring patient safety and improving healthcare outcomes by systematically evaluating adverse events. Influence of healthcare professional on causality. Healthcare professionals play a crucial role in the accurate assessment of causality by providing clinical insights and context to reported adverse event. Applications of causality metrics in healthcare. Understanding metrics for causality assessment enables healthcare teams to effectively analyze and mitigate risk associated with adverse events. Collaboration among healthcare teams in assessment. Team dynamics and collaboration among healthcare professionals greatly impact the quality and accuracy of causality assessment in adverse event reporting. Roles of healthcare profession in causality determination vary huge. Why? Very important. Why? Because healthcare professional firstly meet the patients and firstly can notice adverse reaction, and very important to understand a scene and or symptoms of adverse reaction or disease of patient or comorbidity of patient or drugs which take patients in this time. Why healthcare professionals should have deep academic knowledge of clinical pharmacology, medicine, and drug safety and pharmacovigilance, because drug safety it's about adverse reaction of drugs, drug-induced disorders, it's drug-drug interaction, and as problem as can be adverse reaction or not enough efficacy and efficacy of drugs, lack of efficacy of drugs can happen too. Healthcare professional responsibilities and causality hold significant responsibility in determining causality, impacted treatment decision and patient safety. Interprofessional collaboration in adverse event analysis. Interprofessional collaboration is essential for gathering diverse perspectives and enhancing the reliability of causality determination. Training healthcare workers in causality assessment. Ongoing training of healthcare workers in causality assessment enhancing their ability to recognize and report adverse events actually. Causality has criteria. We will talk now about it. Criteria for causality of adverse reaction. First of all, it's a temporal relationship. The adverse event occurs within a time frame that aligns with the administration of the drug. Criteria: the adverse event occurs shortly after the drug is administered. The event resolves or improves upon drug discontinuation. The challenge: the event reappears if the drug is reintroduced. The challenge. Example: patient develops hives with an hour of taking penicillin, which resolves after the drug is stopped. You should take into account that some adverse reaction can happen at once after administration or after some time. For example, 15 minutes, 1 hour, 2 hours can happen and can appear after in days, months after months, but Some of them, for example, nephropathy after gadolinium containing X-ray drugs can happen after 1 year, and it's very important to make this causality taken into account duration after administration of drug. Second, it's plausibility, biological plausibility, and pharmacological plausibility. Definition of this for understanding this biological or pharmacological explanation that supports the relationship between the drug and adverse event. Criteria: the drug mechanism of action can logically explain the adverse event. The adverse event is consistent with the drug known pharmacological effects. Example: an NSAID, an steroid anti-inflammation drug causing gastric irritation and ulceration, is biologically plausible due to the inhibition of protective prostaglandins in the stomach lining. Consistency with known drug profile definitions, the adverse event aligns with known data about the drug, including clinical trials results, post-marketing surveillance, and documented side effects. Criteria: it includes the adverse event has been previously reported or is listed as known side effect. Similar reactions have been observed in clinical trials or other patients. Example: a patient experiencing dry cough after taking ACE inhibitor and enzyme converted inhibitor is consistent, for example, lisinopril, perindopril, with known side effect of the drug class. And it's very important because a physician can take it like symptoms of bronchitis, but it can be symptoms of administration of, for example, lisinopril, perindopril. It's class specific adverse reaction, and why drug safety knowledge are very important for every specialty of medical doctors, not just physicians, therapists, cardiology, gastroenterology, but surgery, and even diagnostic specialization. Why? Because adverse reaction can happen after administration of every drug, and it's sometimes you cannot predict of it because of sensitivity of patient, hypersensitivity of patient for some group of drugs. Why should doctors be very has warning of it that this can happen, adverse reaction. Exclusion of other causes, definition, the process of ruling out alternative explanation for the adverse event, such as other medication, underlying disease, or environmental factors. Criteria: no other drugs or condition can reasonably explain the adverse event. The event cannot be attributed to concurrent illness or treatment. Example: a patient on multiple medication develops a rash. After stopping each drug sequentially, the rash resolves only when a particular drug is discontinued, ruling out other causes. Dose-response relationship definition: the relationship between the dose of the drug and the severity of occurrence of the adverse event. Criteria: higher doses of the drug are associated with more severe or more frequent adverse events. The adverse event occurs only a certain dose thresholds. Example: a patient experienced sedation that intensified with increasing doses of benzodiazepines. Criteria for causality after adverse reaction rechallenge. Definition: the recurrence of the adverse event when the drug is reintroduced after the event is resolved upon discontinuation. Criteria: The adverse event reoccurs upon administration of the drug, strongly indicated a causal relationship. Example, a patient develops liver enzyme elevation after starting a drug which again. The challenge definition, the improvement or resolution of adverse event after the drug is discontinued. Criteria, the adverse event diminishes or completely resolves when the drug is withdrawn. Example can be a patient gastrointestinal symptoms resolve after stopping an steroid drugs, anti-inflammation drugs like diclofenac, for example, or ibuprofen. Criteria for causality of adverse reaction specificity definition the degree to which the adverse event is specific to the drug or is typically associated with the drug of class of drug. Criteria the adverse event is rare and typically associated with a specific drug. The reaction does not commonly occur with other drugs. Example, Stevens-Jones syndrome, while rare, has a strong association with the cetan anticonvulsant. Previous knowledge of case reports. Definition. The presence of previous report or documented cases of similar adverse event associated with the drug. Criteria. The adverse event has been previously documented in the literature or in clinical databases. Example, a known rare side effect such as agranulocytosis with clozapine is reported in a new case. Statistical and epidemiological evidence. Definition can be evidence from studies or database showing an increase in frequency or adverse events in a patient using the drug compared to those who are not. Criteria. Epidemiological studies or spontaneous reporting databases or spontaneous reported databases show a higher incidence of the event among drug users. Example, an epidemiological study linking long-term use of certain antihypertensive drugs with an increased risk of cancer. Type of adverse event, its 11th criteria for causality of adverse reaction. Definitions, the nature and seriousness of the adverse event may influence the assessment of causality. Criteria, serious or life-threatening events often prompt more intensive investigation and consideration of causality. Example can be anaphylaxis following a new drug administration is highly likely to be drug-related. Understanding causality assessment metric and their application. K-metric is causality assessment tools. Familiarity with K-metrics in causality assessments enhances the ability to evaluate the relationship between adverse events and interventions. Application algorithm causality assessment. Utilizing algorithm causality assessment streamlines the process and improves the accuracy of evaluation in healthcare setting. Innovative tools for causality assessment in healthcare is an interesting topic and very actual because we will talk now and about the role of artificial intelligence and machine learning, natural language processing, big data analytics, Bayesian network statistical models, pharmacovigilance software platform, and mobile health application. Artificial intelligence and machine learning algorithms for automatic causality detection now using analysis of large database ETR spontaneous reporting systems, natural language processing, extraction and analysis of adverse reaction reports, identification of causal patterns from clinical notes, big data analytics, real-time monitoring of healthcare databases, rapid detection of drug event association, Bayesian network statistical models, probabilistic methods for quantifying causality, improved predictive accuracy, pharmacovigilance software platform, integrated system for structured causality assessment, VG-based PV signal, enhanced visualization and decision-making capability, mobile health and health application, patient-reported outcomes collected in real time, direct integration into causality assessment workflows. Imagining Technologies Causality Assessment Tool, its artificial intelligence is revolutionized causality assessment by providing innovative algorithms that enhance the accuracy and efficiency of evaluated adverse events. Machine learning techniques are increasingly being integrated into causality assessment tools, leading to more reliable outcomes, improved patient safety. Algorithmic causality assessment for medical cases. Tools and algorithms for causality assessment. Causality assessment tools and algorithms help clinicians and pharmacovigilance professionals systematically evaluate whether a particular drug is likely to have caused an observed adverse drug reaction. The tools provide structured methods for analyzing the relationship between drug exposure and the adverse event, considering factors such as timing, clinical characteristics, alternative causes, and previous knowledge of drug effects. Naranjo Adverse Drug Reaction Probability Scale, also known as the Naranjo Adverse Drug Reaction Probability Scale, is a structured tool widely used in pharmacovigilance to assess the likelihood that an adverse event is caused by medication. Developed by Naranjo in 1981, it provides a systemic method to determine causality, categorizes the adverse reaction, is definite, probable, possible, or doubtful. Each question within the Naranjo algorithm has defined scoring criteria based on the following responses: yes, no, or do not know. Depending on the answer, a specific numeric value is assigned. Naranjo adverse drug reaction probability scales include 10 questions and their associated scoring values are there previous conclusive reports on this reaction? Yes plus 1, no 0, or do not know 0. Did the adverse events appear after the suspected drug was administered? Yes plus 2, no minus 1, do not know 1. Did the adverse reaction improve when the drug was discontinued or was a specific antagonist administered? Yes plus 1, no 0, do not know 0. Did the adverse reaction reappear when the drug was re-administered? Re-challenge. Yes plus 1, no minus 1, do not know 0. Are there alternative causes other than the drugs that could on their own have caused the reaction? Yes minus 1, no plus 2, do not know 0. Did the reaction reappear when a placebo was administered? Yes minus 1, no plus 1, do not know 0. Was the drug detected in blood or the bodily fluids in concentration known to be toxic? Yes plus 1, no 0, do not know 0. Was the reaction more severe when the dose was increased or less severe when the dose was decreased? Dose-response relationship. Yes plus 1, no 0, do not know 0. Did the patient have a similar reaction to the same or similar drugs in a previous exposure? Was the adverse event confirmed by objective evidence, clinical examination, laboratory test? Yes, +1, no 0, do not know 0. Probability scale, Naranjo adverse drug reaction probability scale has column interpretation. After answering all 10 questions, the assigning points are assumed to provide an overall causality assessment which falls into one of four categories. More or equal 9 points, definite adverse reaction, strong evidence that the drug caused the event. 5-8 points, probable adverse reaction, good evidence but not conclusive. 1-4 points, possible adverse reaction could be related but alternative explanation exists. And equal or less 0 points, doubtful adverse reaction, unlikely to be related to the drug. We now will talk about examples, definite adverse allergic reaction clinical scenario. A 32-year-old male patient was prescribed amoxicillin 500 milligrams 3 times daily for acute tonsillitis. After taking his second dose, the patient experienced a sudden onset of generalized hives, urticaria, facial swelling, and difficulty breathing. He was immediately hospitalized and treated with antihistamines, steroids, and epinephrine. Symptoms quickly resolved after stopping amoxicillin. Application of the Naranjo algorithm. Previous conclusive reports. Yes, amoxicillin is known to cause several allergic reactions +1. Even after drug administration. Yes, immediate after second dose +2. Improved after withdrawal treatment. Yes, rapidly improved after stopping drug +1. Reaction reappeared after a challenge not performed due to life-threatening nature, 0. Alternative causes, no other plausible causes identified, +2. Placebo challenge, not done, 0. Toxic drug concentration, not measured, 0. Dose-response relationship, not tested, 0. Similar reaction not previously exposed reported, 0. Objective confirmation, clinical observation and hospital documentation +1. Total score 7 points, probably ADR according to Naranjo criteria. Clinical note. Clinically, this scenario strongly suggests a definite adverse reaction. However, the formal Naranjo scoring does not reach definite without rechallenge, which is ethically contraindicated. Practically, clinicians interpret this as definitive allergic reaction. Example 2. Probable adverse drug reaction. Clinical scenario. A 45-year-old male patient diagnosed with chronic lower back pain was prescribed diclofenac at a dose of 50 milligrams twice daily. After 1 week of treatment, the patient experienced gastrointestinal bleeding characterized by black tarry stool, melena confirmed by positive stool testing for blood. Naranjo algorithm evaluation. Are the previous conclusive reports of this reaction? Yes, gastrointestinal bleeding is a known adverse reaction of diclofenac, +1 point. Did the adverse event appear after suspected drugs was administered? Yes, gastrointestinal bleeding starting within a week of drug administration, +2 points. Did the adverse reaction improve when the drug was discontinued or was a specific antagonist administered? Yes, the bleeding resolved after discontinuing diclofenac, +1 point. Did the adverse reaction reappear when the drug was readministered? This step was not performed due to ethical reason, risk of harm, 0 points. Are there alternative causes that could on their own have caused the reaction? No. Alternative risk factors or medications that might cause bleeding were identified, plus 2 points. Did the reaction reappear when a placebo was administered? No performed, 0 points. Was the drug detected in blood or other fluids in concentration known to be toxic? No toxicology measurements was done, 0 points. Was the reaction more severe when the dose was increased or less severe when the dose was decreased? Dose adjustment was not attempted, 0 points. Did the patient have a similar reaction to the same or similar drugs in any previous exposure? No history or previous reaction, 0 points. Was the adverse event confirmed by objective evidence? Yes, melena and positive stool testing were objectively confirmed, plus 1 point. Total score, 7 points. Interpretation. The gastrointestinal bleeding is classified as probable adverse drug reaction to diclofenac. Example 3. Possible adverse reaction, mild uncertain reaction. Clinical scenario. 67 years old female patient with diabetes mellitus and hypertension was taking multiply medication, metformin, lisinopril, and atorvastatin. Atorvastatin 20 mg daily was initiated 4 weeks prior. The patient reported mild muscle pain and fatigue after approximately 1 month of atorvastatin use. Symptoms continued despite briefly withholding atorvastatin for 5 days. Naranjo algorithm evaluation. Are the previous conclusive reports on this reaction? Yes, muscle pain, fatigue are no adverse reaction of atorvastatin, plus 1 point. Did the adverse event appear after the suspected drug was administered? Yes, symptoms appeared approximately 4 weeks after initiation, plus 2 points. Did the adverse reaction improve when the drug was discontinued or was a specific antagonist administered? No noticeable improvement after temporary discontinuation atorvastatin, 0 points. Did the adverse reaction reappear when the drug was readministered? No performed, 0 points. Other alternative causes that call on their own have caused the reaction. Yes, multiply medication, age, diabetes, hypertension might also explain symptoms, minus 1 point. Did the reaction reappear when a placebo was administered? Not performed, 0 points. Was the drug detected in blood or other fluids in concentration known to be toxic? No measure, 0 points. Was the reaction more severe when the dose was increased or less severe when the dose was decreased? Dose change was not performed, 0 points. Did the patient have a similar reaction to the same or similar drugs in any previous exposure? No similar reaction reported before, 0 points. Was the adverse event confirmed by objective evidence? No. Subjective compliance only, 0 points. Total score, 2 points. Interpretation. Given the complexity and multiply potential contributing factors, this scenario represents a possible adverse reaction according to the Naranjo criteria. Example 4. Doubtful adverse reaction, statin-associated fatigue with multiply contributing factors. Clinical scenario. A 70-year-old diabetic patient started taking simvastatin 20 mg daily. After 3 months, the patient reported fatigue. However, he also has diabetes, chronic kidney disease, and heart failure, condition independently associated with fatigue. Stopping simvastatin temporarily did not noticeably improve symptoms. Application of the Naranjo algorithm. Previously conclusive reports, fatigue occasionally reported but non-specific. 0. Event after drug administration. Yes, fatigue appeared after drug initiation. +2. Improved after withdrawal treatment. No noticeable improvement upon temporary discontinuation. Reaction reappeared after rechallenge, not performed. Alternative causes. Multiply plausible alternative causes identified. Placebo rechallenge, not performed. Toxic drug concentration, not measured. 0. Dose-response relationship, not tested. 0. Similar reaction previously, not reported previously. 0. Objective confirmation, subjective symptom only. 0. Total score, 1 point. Possible adverse reaction by very weak association. Clinical note. Given the multiple alternative causes, this case is best classified clinically as doubtful, even though it scores as possible according to strict Naranjo scoring. Clinical judgment suggests no strong causal link in this case. Now we will talk about next causality methodology, which for detection it's WHO-UMC Causality Assessment methodology. This methodology, the WHO-UMC Causality Assessment method, is one of the most commonly used tools worldwide for evaluating the likelihood that an adverse event is caused by a particular medication. Developed by the World Health Organization in collaboration with the Uppsala Monitoring Center, this approach is widely adopted due to simplicity, flexibility, and clinical applicability. Principles of World Health methodology. The system uses explicit criteria based primarily on clinical judgment, considering factors such as temporal relationship between drug intake and adverse event onset, response to drug withdrawal, dechallenge, response to drug reintroduction, rechallenge if applicable, presence or alternative explanation or underlying condition, and pharmacological plausibility and documented literature. WHO-UMC causality categories classified adverse drug reaction into 6 clearly defined categories, and what important that it's go from strongest to weakest causal association. First of all, it's certain definite causality category is include clear temporal relationship with drug administration, improvement upon withdrawal, positive dechallenge, recurrence upon reintroduction, positive rechallenge, improvement withdrawal dechallenge, and recurrence upon reintroduction, positive rechallenge. No plausible alternative explanation. Supporting pharmacology mechanism of established literature. Example case Satan. A patient taking penicillin develops anaphylactic shock minutes after administration. Symptoms resolve after stopping penicillin and recur upon accidental re-administration. Probable likely causality. Reasonable temporal relationship to drug administration. Reaction improves on drug withdrawal, positive dechallenge. Rechallenge information is typically lacking or unavailable. Alternative explanation less likely than drug cause. Example case probably a patient taking ibuprofen regularly for 10 days experiences gastrointestinal bleeding. The bleeding stops after discontinuation. Rechallenge is not performed due to ethical concern. Possible categories. Reaction has reasonable temporal relationship to drug intake. Reaction could be explained by drug, but alternative explanation also exists. Information on drug withdrawal may be lacking or inconclusive. Example case possible. A patient taking multiple medication, including an antibiotic, develops mild liver enzyme elevation. The antibiotic could be responsible, but another medication or an underlying disease might also cause the elevation. Limited information exists regarding resolution upon withdrawal. Unlikely, the reaction has a temporal relationship incompatible with the drug administration. Other causes clearly explain the reaction. Little pharmacological plausibility or supported literature exists. Example cases unlikely. A patient develops symptoms of influenza shortly after starting antihypertensive therapy during flu season. The timing and clinical signs strongly suggest influenza infection rather than drug-induced. Conditional and classified. The case required more data for proper assessment. Information currently insufficient or incomplete for classification. Example case conditional. The patient reports non-specific symptoms, fatigue, headache after drug initiation, but not further data. Laboratory test follow-up is available for causality evaluation. And sixth category is unaccessible, unclassifiable category. Report insufficient or contradictory to allow meaningful assessment. Essential information missing or unreliable. Example case unaccessible. A brief spontaneous report stated only that patient had adverse effect without specified symptoms, timing, or other essential details. Practical use of WHO-UMC methodology in pharmacovigilance. It's widely utilized by national pharmacovigilance centers globally, facilitates consistency in the evaluation and comparison of adverse reaction reports, provide clear, standardized communication between healthcare professionals, regulators, and manufacturers. Comparing, when you would like compare WHO-UMC to the Naranjo algorithm, the WHO-UMC methodology relies more heavily on clinical judgment, making it inflexible and practical in diverse clinical settings. In contrast, the Naranjo algorithm is more structured, providing numerous scores but less flexible in complex clinical scenarios. The WHO-UMC is particularly suited for real-world pharmacovigilance databases and spontaneous reporting systems. Now we will talk case studies using the WHO-UMC causality categories. First of all, it's a category certain definite clinical scenario. 27 years old male patient received intravenous injection of ceftriaxone for a bacterial respiratory infection. Within minutes after administration, the patient developed a severe allergic reaction, urticaria, swelling, and bronchospasm. The medication was immediately stopped and antihistamines and corticosteroids were administered. Symptoms rapidly resolved. 3 months later, the patient accidentally received ceftriaxone again and the identical allergic reaction recurring instantly. The WHO-UMC assessment result. Temporal relationship clear and immediate after administration. The challenge positive rapid resolution after stopping drug. Rechallenge positive recurrence on re-exposure. Alternative explanation non-plausible. Pharmacological plausibility non-drug induced hypertensivity. Causality category setting. Case study 2 probably likely. Clinical scenario: a 60 years old woman was started on diclofenac 50 mg twice daily for joint pain. After approximately 2 weeks, she developed severe abdominal pain and gastrointestinal bleeding confirmed by endoscopy. Diclofenac was stopped, proton pump inhibitors were initiated, and symptoms resolved within days. A rechallenge was not conducted due to ethical concerns. We show UMC assessment results. Temporal relationship clear. Symptoms occurred shortly after treatment initiation. The challenge positive resolution after stopping diclofenac. Rechallenge not performed, ethically inappropriate. Alternative explanation unlikely no other causative medication or condition identified. Pharmacology plausibility strong diclofenac known to cause gastrointestinal bleeding. Causality category probably likely. Case study 3 category possible. Clinical scenario: a 65 years old diabetic patient began taking metformin for type 2 diabetes mellitus. 2 months later, the patient developed mild elevation in liver enzymes IL-10 IST. Metformin was suspected, but the patient was simultaneously taking several medications for hypertension and hyperlipidemia. The elevation in liver enzymes slightly improved but did not normalize upon discontinuation of metformin, leaving uncertainty about the exact cause. The UMC assessment, temporal relationship, reasonable but delayed, the challenge, partial improvement but inconclusive, rechallenge not performed, alternative explanation, possible multiply medication, chronic condition, fatty liver. Pharmacology plausibility, metformin rarely causes liver enzyme elevation, but it's possible. Causality category possible. Case study 4 unlikely. Clinical scenario: a 40-year-old patient started therapy with antihypertensive drug amlodipine. One day after starting treatment, the patient presented symptoms of severe sore throat, fever, and fatigue. Clinical evaluation, a laboratory test confirmed acute streptococcal pharyngitis and infection cause clearly unrelated to amlodipine. Amlodipine is a blocker of calcium channels. WHO-UMC assessment, temporal relationship present but unrelated to soon and symptoms indicative of infection. The challenge not relevant, rechallenge not relevant. Alternative explanation clearly identifying infection cause, streptococcal infection. Pharmacology flexibility, none of amlodipine causing acute infection symptoms. Causality category unlikely. Case study 5 conditional unclassified category. Clinical scenario: a 55-year-old woman started treatment with a new antidepressant sertraline. After a few weeks, she reported generalized fatigue and mild dizziness. However, no further clinical information, follow-up examination, or laboratory tests were available to clearly associate or dissociate the symptoms from sertraline. The UMC assessment, temporal relationship possibly present, the challenge not evaluated, insufficient information, rechallenge not evaluated, alternative explanation unknown due to lack of further data, pharmacology possibility possible but not clearly defined, causality category conditional unclassified. Case study 6 unaccessible unclassifiable. Clinical scenario: a spontaneous adverse report received states only patient experiencing discomfort after started medication without specifying the medication name, the type of discomfort, the timing, or other details. Follow-up attempts failed to gather additional information. The UMC assessment, temporal relationship, non-accessible. The challenge, unknown. Re-challenge, unknown. Alternative explanation, cannot assess. Pharmacologic possibility, unknown. Drug name and reaction, unclear. Causality category, unaccessible, unclassifiable. Machine learning algorithms for causality determination. First of all, it's common experts in machine learning and causality assessment identified key professionals and researchers who are driving innovation in the use of machine learning for assessing causality in medical cases. Exploring advanced algorithmic causality into how machine learning enhances the precision of causality determination in adverse events, employing various algorithmic strategies. Algorithmic framework enhancing causality investigation. Examine the frameworks that support algorithmic approaches in causality assessment, facilitated better decision-making processes. Evaluating the efficacy of causality assessment tools. A critical evaluation of different machine learning tools utilized in causality assessment and their effectiveness in real-world application. Collaboration among data scientists and causality analysis. The importance of interdisciplinary collaboration in causality. Understanding how collaboration among data scientists, clinicians, and biostatisticians leads to improved causality. Best practices for data scientists and causality analysis. Outlining effective strategies and practices the data scientists can adopt for successful collaboration in analyzing causality. Notable figures in causality analysis collaborations, highlighting prominent individuals who have significantly contributed to the collaborative efforts in enhancing causality assessment methodologies. Impacts of teamwork on causality evaluation outcomes, investigating how collaborative efforts among data scientists influence the outcomes and accuracy of causality evaluation. Algorithmic approaches to enhance causality assessment accuracy. Innovative algorithmic methods for curative assessment. An overview of new algorithmic methods designed to improve the accuracy of causality assessment and adverse event reporting. Key contributors to algorithm development causality, identified professionals who have made substantial contribution to the development of algorithm for causality assessment. Challenges faced in algorithmic causality assessment, discussing the challenges that researchers and practitioners encounter when implemented algorithm approaches in causality assessment. Future direction for algorithmic causality assessment, exploring the potential future advancement in algorithmic techniques that could further enhance the accuracy of causality evaluation. Case studies on causality assessment methodology used. First of all, understanding the criteria for causality evaluation tool, exploring the various criteria used in causality assessment tools can enhance the accuracy of adverse event evaluation. Key algorithms applied in adverse event analysis. Analysis algorithms that automate causality assessment can streamline decision-making processes within healthcare. People experience it with causality assessment challenges. Insights from healthcare professionals reveal common challenges faced during the causality assessment process. Insight from healthcare teams on assessment challenges. First of all, the role of healthcare professional causality assessment. The contribution of healthcare professionals can inform improvements in assessment protocols. Navigating complexities in causality assessment. Teams frequently encounter barriers that complicate the workflow on causality assessment. Collaborative strategy Technology challenges causality assessment and collaborative strategies to overcome assessment. Its main insights from healthcare teams of assessment challenging. Lessons learned from real-world causality assessment. Its evaluated outcomes of past assessment methodologies. Analyzing past case studies can yield a valuable reason for improving future causality assessment. People perspective on effective assessment practice. Gathering perspective from various stakeholders can highlight effective practices in causality assessment. Challenges facing in real-world case assessment. Exploring challenges observed in real-world cases can provide insight into improving methodologies. People involved in causality assessment and their roles. Key stakeholders and adverse event causality evaluation. The roles of clinicians in evaluated causality assessment. Clinicians play a pivotal role in assessing adverse events by providing clinical insight and patient history, which are essential for accurate causality evaluation. Impact of regulatory professionals on causality analysis. Regulatory professionals contribute to causality assessments by ensuring compliance with the guidelines and providing framework for evaluating the relationship between adverse events and treatment. Collaboration between pharmacists and physician causality. Pharmacists collaborate with physicians to review medication history and assess potential drug-related adverse events, enhancing the quality of causality assessment. Contribution of multidisciplinary teams in causality. The importance of team approach in causality evaluation. Its multidisciplinary teams enhances the quality of causality assessment by incorporating diverse expertise, leading to a more comprehensive understanding of adverse events. Involvement of data analysts in causality determination. Data analysts contribute to causality assessment by applying statistical methods to evaluate trends and correlation between adverse events and treatments. How social workers aid in causality analysis to adverse reaction. Uh, Social workers provide crucial insight into the social determinants of health which can affect the interpretation of adverse events in causality assessment. Psychologists' role in understanding patient-reported can help interpret the patient-reported outcomes in causality assessment, focusing on the psychology impact of adverse events and treatment relationship. Profiles of healthcare professional causality analysis. Characteristic of effective causality assessors in healthcare. Effective causality assessor possesses strong analytical skills and comprehensive understanding of clinical guidelines, enables them to determine a relationship between treatment and adverse events. The influence of medical research on causality. Role nurses of frontline causality evaluation. Nurses serve as a front line in patient care and can provide essential observation and documentation of adverse events, aiding an accurate causality evaluation. Importance of communication skills and causality analysis. Healthcare professionals involved in causality analysis must have strong communication skills to effectively collaborate and convey findings among multidisciplinary teams. Evaluating adverse events through various causal tools. Evaluate framework for assessing causality in events. It's a collaborative effort in causality assessment. The importance of teamwork among healthcare professionals is crucial in this role's evaluation of adverse events and causality assessment. Exploring framework for causality evaluation. This section discusses various frameworks using evaluation of causality within adverse events, emphasizing the criteria and methodologies. Best practices for evaluative framework and integrated algorithms in causality evaluation. In interprofessional roles and adverse events tools, the roles of clinicians and causality tools, team dynamics, causality assessment, and collaboration in adverse event analysis. Tools for enhancing teamwork and causality, innovation in teamwork tools, training teams for effective causality evaluation, training healthcare teams is using causality assessment tools is crucial for improving the evaluation and management of adverse reaction. The significance of communication in teams, effective communication strategies are essential for teamwork in causality assessments, ensuring accurate evaluation. Evaluating teamwork effectiveness in assessment method to evaluate the effectiveness of teamwork in the context of causality assessment are discussed. Dear colleagues, thank you very much for your attention, for your participation. I was thankful for your comments and for your question. You can send me and use an YouTube channel, and you can send and ask me and your needs by email. Please subscribe to my YouTube channel. It will be increase audience and help people to get new knowledge. Please visit my website allmedicine.net.